Welcome, everyone. I'm Jody Hoyos, President and Chief Operating Officer of the Prevent Cancer Foundation. Thank you for joining us for our third and final webcast of the 2021 Prevent Cancer Dialogue. For those of you joining us for the first time today, and those of you who are with us for our first and second webcasts, thank you for engaging with us, for dialoguing with us about critical issues on health equity and innovations in cancer screening. Despite the virtual format, we're typically in person, and really in many ways because of it, we were able to have really valuable conversations that shape our ideas, our perspective, and our practice. And I'd like to take a moment to acknowledge our sponsors for their generous support of this event. Without them, those conversations could not take place. The full list of sponsors is located on our website, but I'd like to highlight with special thanks two of our top sponsors, Grail and Exact Sciences. The theme of today's webcast is progress and challenges in cancer screening. The presentations will include what's new, what's innovative, and what's coming down the pike. And the topics include genetics and genomics, single and multi-organ cancer screening, as well as options for colorectal cancer screening during the pandemic, and of course, much more. And before we conclude the webcast today, we'll be presenting the 2021 Cancer Prevention Laurels Awards, hosted by Andrea Rohn. Please stay tuned as we honor your colleagues for their work in increasing health equity through innovation, community support, and leadership. And now it is my pleasure to introduce the moderator for our first panel, who will be facilitating discussion on genetics and genomics in public health. Please welcome Lisa Schlager, Vice President of Public Policy at FORCE. Thank you.
Sharing that I have, thank you, Jody, for the warm welcome. I'd like to start out by saying that I have no conflicts of interest relevant to today's meeting. Yes, I am the Vice President of Public Policy for a national nonprofit called FORCE. Our focus is hereditary cancers, and I'm very pleased to be here with you today to share some wonderful information as part of this Prevent Cancer Foundation event. We're going to start off with some brief biographies for our speakers. So first and foremost, I'd like to share a little bit about Heather Hampel. She is a professor in the Department of Internal Medicine and Associate Director of the Division of Human Genetics at the Ohio State University Comprehensive Cancer Center. Her research focuses on Lynch syndrome, an inherited cancer syndrome, and universal tumor testing for that syndrome. She has more than 160 publications on this topic, specifically among colorectal and endometrial cancer patients. Next up will be Dr. Alice Berger. She is the assistant professor and of the Innovators Network Endowed Chair at the Fred Hutchinson Cancer Research Center in Seattle, Washington. Her laboratory applies genomics and functional genomics technology to discover mechanisms of lung cancer and develops new strategies for lung cancer therapy. She was named the Devereaux Outstanding Young Investigator by the Prevent Cancer Foundation for her work on the genomics of lung cancer in women. She'll provide us with some information about the rising incidence of lung cancer in never smokers and an overview of the clinical utility of genomic sequencing in this population. Next is Dr. Lisa Aspinwall. She's the professor of psychology at the University of Utah and a member of the Huntsman Cancer Institute's Cancer Control and Population Sciences program. As a social and health psychologist, her research examines how people seek to understand, anticipate, prevent, or manage negative outcomes, especially in the area of familial cancer. She will be partnering with Dr. Sancy Leachman, who is the chair of the Department of Dermatology at Oregon Health and Science University. And she's also the director of Melanoma Research Program at OHSU Knight Cancer Institute. The inaugural recipient of the John D. Gray Endowed Chair in Melanoma Research and chair of the Southwest Oncology Group Melanoma Prevention Working Group. She's a dermatologist who uses basic science research and state-of-the-art technology to combat skin cancer. She and Dr. Aspinwall will discuss the value of sharing genetic test results with people at high risk of melanoma in order to motivate changes in behavior. I'd like to circle back and say that Dr. Hampel is going to provide us with a solid foundation of information about the use of genetics and genomics in cancer prevention and early detection. So we do plan to hold questions until the end. We would greatly appreciate that. You can ask your questions and comments by clicking the Q&A icon at the bottom right of your screen. So let's get started with our first presentation from Heather Hampel, who's going to be followed by Alice Berger, Sandy Leachman, and Lisa Aspinwall. Thank you. Let's get started.
Thanks so much, Lisa. It's really a pleasure to be here. As she said, my name is Heather Hampel, and I am the Associate Director of the Division of Human Genetics at The Ohio State University, where I've been a cancer genetic counselor for the past 23 and a half years. Today, I'm going to be talking to you about what you've always wanted to know about genetics and genomics in cancer prevention and early detection. And if you like to tweet, my Twitter handle is right there on the screen. I do have a few disclosures. I'm on a couple scientific advisory boards and have stock or stock options in one of the companies in which I'm on the scientific advisory board for, and a company that's working with the American College of Gastroenterology to provide genetic services. None of those will impact on my talk today. So I want to talk to you, take you first back a little bit to some basic genetics. And I actually do this with my patients in clinic. And I think it's a great way of understanding how cancer susceptibilities work. So as you know, we all have 46 chromosomes. You get 23 from your mom and 23 from your dad. So they come in pairs like you see here on the screen. Each chromosome has thousands of genes on it. There's about 20,000 genes altogether strung along these 46 chromosomes. And each gene codes for one protein or substance that your body needs to grow and develop properly. So I like to say the mix of these 20,000 genes is the recipe for you, determining things like hair color, eye color, height, and as we're starting to learn, predispositions to certain diseases. So there are genes among these 20,000, whose job it is really to protect us from getting cancer. We call them tumor suppressor genes. I like to describe them sometimes to my patients as the brakes in the car. As long as they're working, the brakes stay on, and the cells grow nice and slowly, dividing when they should and dying when they should. So all of us have these genes, and we want them to be working. So what happens in somebody with an inherited cancer susceptibility syndrome? Let's look on the right side of the screen. So here you'll see both pedigree, which is a family history as we draw them in cancer genetics, where squares are women and circles, or squares are men and circles are women. So here you'll see in this bottom generation, a young woman who has cancer. She has a brother. If you move up a generation, her father had cancer. There's her mom. Moving to the left, a paternal aunt had cancer and a paternal grandmother had cancer. So here we have what we would consider a 3-generation family history of cancer, and that is going to raise some red flags about an inherited cancer susceptibility syndrome. What happens in our inherited cancer susceptibility syndromes is that somebody is born with what we call a pathogenic variant, or they used to be called a mutation, some sort of mistake in one of those tumor suppressor genes that we talked about. And because that's inherited from their mom or their dad, it's in every cell of their body from the day they're born. Luckily, we have 2 copies of every gene. So if we have one copy that's not working, inherited from our mom or our dad in every cell of our body, we have another copy that is working just fine from our other parent. And the good news is that working copy is going to compensate for many years, and the tumor suppressor works, and we don't get cancer. So we don't typically see a lot of childhood cancers in these inherited cancer susceptibility syndromes. They're more adult onset. And the reason is that one day over the years, the odds are pretty high that just by chance, as our cells are dividing, one of our at-risk cells will acquire a mistake in the working copy. And so now you have a cell that has no more working tumor suppressor gene. The brakes come off, the cell starts to grow too fast, doesn't die when it should, and that cell becomes the cancer. So basically, people with an inherited cancer susceptibility syndrome are born one step closer to getting a cancer because of having that one copy of that tumor suppressor gene not working in every cell of their body from the day they're born. So when we do genetic testing, we can tell people whether they have this mutation or not. What we can't tell them is when the second mistake will occur. And when you look at a hereditary cancer family, you might see one person with cancer at age 36 and another who didn't get cancer until age 52. And that's just all left up to chance and when those second mistakes happen during our lifetime. We can't tell them where they'll get a cancer, but we do know the organs that are at increased risk. So depending on which gene is not working, that tells us which cancers they're at higher risk for. And so we can screen or try prevention options for those specific cancer. We also can't tell them how many times this will happen. And so a red flag for a hereditary cancer syndrome is always a person who's had more than one primary cancer. I'm not talking about recurrences or metastases. I'm talking about whole new primary cancers. So any of us could get a cancer in our lifetime. In fact, 1 in 3 of us will. But when you see someone get 2 different cancers in their lifetime, you start thinking maybe there's an underlying susceptibility there. And so that is another red flag because the second mistake can happen 1 year, successfully treat that cancer. 6 years later, it happens again, and we have a whole new primary cancer. So this would even apply to things like bilateral breast cancer, where you have it in your right breast. 6 years later, you get it in your left breast, a whole new primary, not spread or recurrence from the first one. We also can't tell people for sure that they will even get a cancer if they're born with one of these mutations. The risk is higher, but it's not 100%. So some people just don't get that second mistake and never get a cancer. And I have found 100-year-old people who have the mutation that's running in their family and just have never gotten cancer. And certainly we're interested, in studying, was there anything they did or didn't do in their life that might have helped keep them from getting cancer, but it may have just been chance. So you'll see under the family tree here that the red flags that we're going to look for hereditary cancer syndrome, which we've kind of talked about, is this earlier age of diagnosis. Because you're one step closer, it doesn't take as long on average. So earlier ages of diagnosis is a red flag that the cancer might be hereditary. The multiple generations with cancer. That's more concerning than a couple siblings with cancer because we call it a vertical transmission pattern where you can see it getting passed down through the generations. Bilateral or multiple primary cancers we've talked about, and then clustering of certain cancers that we know go together. I think people are well aware that breast and ovarian cancer run together in families. I don't think people necessarily know that prostate and pancreatic cancer are also seen in our breast ovarian cancer families. And people are much less aware of Lynch syndrome, which we're going to talk about today, which causes an increased risk for colon, uterine, ovarian, and stomach cancers. And I just want to spend 1 second talking about sporadic cancers. So most cancers are not hereditary. We think about, depends on the cancer, but somewhere between 10 and 15% of most cancers are hereditary, with some notable exceptions like ovarian, where it's a much higher percent. So the rest of the cancers are sporadic or familial, which we aren't going to talk about today, but sporadic just means they popped up by chance alone. So you don't tend to see any family history, and these individuals are born with all of these tumor suppressor genes working just fine. Now, as they age, they can acquire these mutations. Maybe the cell dies, nothing comes of it, but if it lives long enough and gets enough of them, it can stop working and we can see a cancer develop. These mutations occurred in the person's body during their lifetime. They were not born with them and they cannot pass them on to their children. These are the mutations that they look for when someone gets tumor sequencing done on their tumor at the time of diagnosis now, which is a growing area of interest, because sometimes our oncologists like to know what are the mutations that are driving that cancer, because sometimes it gives them an idea of what therapies to choose. You'll note that the cancers tend to be diagnosed at later ages with little or no family history and single or unilateral tumors in the sporadic cases. Hereditary cancer syndromes follow an autosomal dominant inheritance pattern for the most part. There are a few exceptions. So if somebody has one of these mutations, like this person on the top left, there is a 50% chance that they'll pass the mutation on to their children. So in this case, that's the capital A. And there is a 50% chance they'll pass their working copy on to their children. Assuming they've married or had children with someone who does not have that mutation, that boils down to a 50% chance for each child that they'll inherit the cancer susceptibility syndrome and have the increased risk for cancer. And if they inherit the mutation, then their children move to the 50% risk. But it's equally likely that they pass on their working copy, then the individual has no increased risk for cancer and cannot pass it on. So it essentially stops there in that branch of the family. So this is very powerful. If we can find a mutation in a family that's causing cancer, we can let the at-risk children, brothers, sisters, aunts, uncles, cousins know if they inherited it or not. And if so, we can implement increased screening and prevention. And if not, that's really great news because they can essentially follow the American Cancer Society guidelines for screening in the general population. So we've kind of hit these already, but when to suspect a hereditary cancer syndrome. So I feel like I get to play detective in my work, and now I'd like to, deputize all of you to do the same. As you think about your own family histories or your friends and family's family histories, do they have these characteristics that make it more likely to be hereditary? And if so, they should probably see cancer genetics. So again, cancer in 2 or more close relatives on the same side of the family. I get a lot of calls from people who say both my mom and dad had cancer. There's a 100% chance I'm going to get cancer. It doesn't work that way. It's actually more concerning if there's several cases on the same side of the family because your mom and dad are not genetically related to each other. Earlier ages of diagnosis, we've mentioned. Multiple primary tumors. That goes with also bilateral tumors. Rare tumors like male breast cancer and some others that are rare can be more likely to be hereditary. And then these combinations like breast, ovarian, prostate, pancreas, or colon, uterine, stomach, ovarian. And then the vertical transmission pattern that we talked about where multiple generations are affected. The most common hereditary cancer syndromes we're going to talk about today. So hereditary breast ovarian cancer syndrome, which is caused by mutations or pathogenic variants in the BRCA1 or BRCA2 genes. We're going to talk about Lynch syndrome, which is due to mutations in one of 5 genes called the mismatch repair genes, MLH1, MSH2, MSH6, PMS2, and EpCAM. That's the one that causes colon, uterine, ovarian, and stomach cancers. And those 2 conditions are considered tier 1 diseases by the CDC. Their third condition that's considered a tier 1 disease is not a cancer syndrome. It's a high cholesterol syndrome that runs in families called familial hypercholesterolemia. These 3 conditions are considered tier 1 because they are common enough in the general population, easy to test for, and they're actionable. There's something we can do about them that makes the person less likely to have a bad outcome. One recent study at the Geisinger in Pennsylvania assessed for these 3 conditions in 50,000 healthy people in their health plan and found that 1.32% or 1 out of 76 individuals had one of these conditions. That's extraordinarily common. Compare that to the 1 in 800 positive rate for newborn screening, which every newborn in America gets a heel stick and gets tested for a number of genetic conditions that are much less common than these 3. And so I think this is a real public health concern. We have estimates that probably 90 to 95% of individuals with hereditary breast ovarian cancer syndrome and Lynch syndrome are not aware of their diagnosis. So we're really trying to work hard to close that gap and get these individuals identified so that they can benefit from screening and prevention. So I mentioned about 10% or 15% of most cancers are hereditary. That is true of breast cancer. There's an additional 15% that are considered familial, where there might be some minor genes plus shared environment, making the family slightly more likely to get breast cancer, but 75% then being sporadic. Ovarian cancer, a full quarter, almost 25% are hereditary, and 76% are sporadic, and there's not really this familial component. The BRCA1 and 2 genes are on chromosomes 17 and 13, and everybody has them, and you want them to be working. If you have a non-working BRCA1 or BRCA2 gene, you have significantly elevated risk for the cancers I've mentioned. And here you can see the general public has this about 13% lifetime risk for breast cancer, and that's around 70% for people with BRCA1 or 2 mutations, so significantly elevated. The ovarian cancer risk is higher with BRCA1, 39 to 58%, compared to BRCA2, where it's 13 to 29%, and the general population, where it's a rare cancer at 1.3%. The prostate cancer risk is significantly elevated, particularly with BRCA2. It's common in the general population as at 12.5%, but could be as high as 27 to 60% with BRCA2 and up to 29% with BRCA1. Pancreatic cancer risk is also elevated, the general public only having a 1.7% chance of getting pancreatic cancer in their lifetime, and again, higher with BRCA2 up to 10%, but elevated also with BRCA1. So when we know someone has one of these mutations, these are the cancers we're going to focus on for early detection and prevention. I do mention briefly that these mutations, there are 3 particular mutations in the BRCA1 and BRCA2 genes, which you see spelled out here, that are more common in Jewish individuals. So sometimes when somebody asks your family history, they might ask about your ancestry and your religious background. And that's because there are certain founder mutations that are more common in certain populations. For example, in Iceland, Denmark, and Finland, the BRCA2 999del5 mutation is extremely common and accounts for almost all of the hereditary breast ovarian cancer there. It means that BRCA1 and 2 mutations are more common in Jewish individuals, about 1 in 40, compared to the general population where it's 1 in 400, so a 10-fold increase. So it doesn't take as much family history for a Jewish family to be referred to genetics as it does for a non-Jewish family. But this has gotten misinterpreted, and we've done some studies in Ohio where we found that people think that non-Jewish individuals can't have hereditary breast ovarian cancer. That is not at all the case. It's very common. It's just more common in Jewish individuals. So I like to make sure that people understand that difference. What is the management if somebody has hereditary breast ovarian cancer syndrome? So for breast cancer, we're going to start breast awareness at age 18. They're going to perform their clinical breast exams every 6 to 12 months, starting at age 25. And at age 25, we're actually going to start imaging with annual breast MRI screening with contrast. The reason we don't start the mammogram yet is the risk of the radiation on a young developing breast. And then at 30, we kick in the mammograms. And so now they're getting a mammogram and an MRI annually. And a lot of people like to spread those out every 6 months because what one might miss, the other might catch. And then you have a chance to pick up any interval cancers instead of doing them both at the same time. After age 75, management's individualized depending on the person's overall health. The other discussion about breast cancer is the consideration of a risk-reducing mastectomy. At a 70% lifetime risk, some people would instead decide to do risk-reducing mastectomy to lower the risk of breast cancer as much as possible. And it has been shown to reduce the risk by about 90%. And the only reason it's not 100% is they can never remove every breast cell. There's still some under the skin and on the chest wall that can't be removed. But significantly decreased risk, lower than the general population. But of course, then there's discussions about what types of reconstruction options there are, and those can sometimes be more complicated, the reconstruction options for people than the mastectomy. And there are some risk reduction agents like chemoprevention with tamoxifen. They have not been popular in women with BRCA1 and 2 gene mutations, but they are effective. They can reduce the risk of breast cancer. So what's the ovarian cancer management? As you all probably know, there is no effective screening for ovarian cancer. So in this case, we opt for prevention through risk-reducing bilateral salpingo-oophorectomy. So that's removing both ovaries and both fallopian tubes between the age of 35 or 40, or after childbearing is complete. Because ovarian cancer in women with BRCA2 mutations occurs a little later than with BRCA1, women with BRCA2 mutations can kind of wait till 40 to 45. There is some evidence of a slight increased risk for a serous uterine cancer among BRCA mutation carriers. So some people will consider a hysterectomy at the same time as their ovaries and fallopian tubes are removed. If someone's delaying that surgery, we recommend that they try a transvaginal ultrasound with color Doppler, starting at age 30 to 35, and a CA-125 blood test to attempt to screen for ovarian cancer. But again, no evidence that that's very effective. Oral contraceptives actually have been shown to reduce the risk of ovarian cancer, and the low doses used today do not increase breast cancer risk significantly. So oral contraceptives are not counterindicated and may decrease the risk for ovarian cancer. For men, breast self-examination and training beginning at age 35, clinical breast exams annually beginning at age 35. With BRCA2, we actually recommend prostate cancer screening, including annual digital rectal exam and PSA tests beginning at age 40. And for BRCA1, consider prostate cancer screening at age 40. Screening for other cancers in both men and women. There's no specific guidelines for melanoma, but it has been seen at a slight increased risk, particularly with BRCA2. So, sun avoidance and annual full body skin exam are not a bad idea and are not invasive. The pancreatic cancer screening, it is recommended for people who have a BRCA1 or 2 mutation if they have a relative with pancreatic cancer. And so we start that at 50 or 10 years younger than the earliest diagnosis, and they either do endoscopic ultrasound or an MRI to look for any kind of cysts that are concerning in the pancreas. All other screening is American Cancer Society guidelines. And now I haven't left myself much time for my favorite syndrome that I work with on research, but Lynch syndrome, as we mentioned, is due to mutations in the mismatch repair genes. These are the 4 main ones, and EpCAM can cause Lynch syndrome, but basically because it shuts down MSH2. Lynch syndrome is common. 1 in 279 individuals have it. It causes colon, uterine, stomach, and ovarian cancer, among others. Those cancers are preventable with earlier and more frequent screening. And again, 90 to 95% of individuals are not aware of their diagnosis. Someone who has Lynch syndrome has elevated risk of colon cancer, and the risks vary depending on which gene is causing it. So you can see as low as 9 to 20% in someone with a PMS2 mutation, and as high as 61% in someone with a pathogenic variant in MLH1 or MSH2. And that compares to the general population risk of 4.2%. Endometrial cancer, 3.1% in the general population, up to 50% in some of the higher risk genes. Stomach cancer, kind of seeing less of that in the US, even among individuals with the higher risk gene mutations, but still elevated. And ovarian cancer risk can be as high as 38% with MLH1 and MSH2. 13% with MSH6. And so I think historically people have thought of BRCA1 and 2 for individuals with ovarian cancer, but they might indeed actually have Lynch syndrome. So what's the screening for Lynch syndrome? For MLH1 and MSH2, they start colonoscopies at age 20 to 25 and repeat it every 1 to 2 years. With MSH6 and PMS2 having the slightly lower risk at later ages, they start at 30 to 35, but again, repeat it every 1 to 2 years. So these individuals are going to get a lot of colonoscopies in their life. But we know if we remove those precancerous polyps, we have a really good chance of preventing colon cancer from occurring even in the first place. For endometrial cancer, really the key is knowing the symptoms. Any bleeding between cycles or after menopause, get right into the gynecologist. Some people do consider a hysterectomy after childbearing, and some people do consider endometrial screening with endometrial biopsies every 1 to 2 years starting in their 30s. There is no evidence that the screening changes outcomes, though, because endometrial cancers tend to get diagnosed early and people do well. Ovarian cancer, same issues as with BRCA1 and 2. So some people do consider removing their ovaries and fallopian tubes after childbearing. For stomach cancers and small bowel cancers, we really kind of only screen if there's a family history. Urinary tract cancers, which can also be seen with Lynch syndrome, we pretty much focus on people who have a positive family history, or particularly men with MSH2 mutations who are known to be at higher risk, and they can do urinalysis annually starting in their 30s. Pancreatic cancer, same screening as with hereditary breast ovarian cancer syndrome, only for people who have a mutation and a family member with pancreatic cancer. It's controversial whether there's any elevated risk for breast or prostate cancer with Lynch syndrome, but even if there is, it's not elevated enough to warrant increased screening. So general population screening. Some evidence of glioblastoma, increased risk with Lynch syndrome, so just an annual physical and neurological exam. Aspirin has been shown to decrease the risk of colon cancer for individuals with Lynch syndrome. So we do recommend that our patients with Lynch syndrome take an aspirin a day for at least 2 years. They're not quite sure of the optimal dose and duration. At this point, a lot of people are recommending a baby aspirin or 1 adult tablet, but there is a study ongoing in Europe that will identify the optimal dose and duration of this treatment. It's very exciting though, because it definitely looks like it decreases the risk by at least 65% for individuals with Lynch syndrome. And lastly, I always like for everyone to know that the only risk of doing genetic testing at this point is this concern about insurance discrimination. So there is a federal law in place called the Genetic Information Non-Discrimination Act, or GINA, and that prevents health insurers or employers from discriminating against someone based on genetic test results or family history. So the only loopholes then are life insurance, disability insurance, and long-term care insurance. So this is something that we always discuss with our patients prior to testing. And some people make sure they have those types of policies in place before they do their testing, because it's less likely to lose a policy that you have than to get rated higher or get denied. But this has been, the GINA law has really given a lot of reassurance to patients who need their health insurance more than anyone else because they need to do this high-risk screening and prevention. So take-home messages are that all cancer is genetic due to genes that are not working properly and are causing those cells to grow out of control and not die when they should. But not all cancer is hereditary due to a mutation that was inherited from a mom or a dad and can be passed on to their children. When you're risk assessing, I'm more concerned about ages of diagnosis than the total number of cases. Ancestry can help change our risk assessment. More rare tumors make a bigger impact on risk. And genetic counseling and testing and identifying these high-risk families allows for the proper cancer screening so that we can keep these individuals from getting cancer in the first place. Thank you so much.
Thank you, Lisa, for the nice introduction. Yes, I'm Alice Berger out at Fred Hutchinson Cancer Research Center in Seattle, Washington, and I have no relevant financial relationships to disclose. Now, some of you, if you've been to Seattle, may realize that this inset photo here is not Seattle, Washington. In fact, that's Morgantown, West Virginia, my hometown where I grew up for many years. Morgantown is a beautiful, idyllic college town a few hours south of Pittsburgh, Pennsylvania, with a population of 31,000. And the reason I'm telling you this is because that was the context by which I was shocked to find out that cancer causes many, many, many more deaths per year than the population of Morgantown, West Virginia. And in particular, lung cancer is the leading cause of cancer deaths worldwide and also in the United States, and also in both men and women, which I think many people still don't know. In fact, together between men and women, lung cancer kills over 135,000 people every year in the United States, which is over 4 times the population of Morgantown, West Virginia. And so as I started studying cancer biology and learned about this, that was part of my motivating reason to study this disease. Now, there are many risk factors for all types of cancers, and these risk factors can either be intrinsic, such as genetic factors, or extrinsic, such as environmental factors. And on the intrinsic side, you can have, for example, genetic mutations. Kind of well-known one is BRCA1, which causes hereditary risk for breast and ovarian cancer. On the extrinsic side, of course, for lung cancer, one of the most, the highest risk factor is smoking exposure. However, as our understanding of lung cancer has grown in the past decade, so has our understanding of the underlying causes of lung cancer. Back in the 80s, when smoking was incredibly prevalent and we had seen this really high increase in lung cancer cases, there was a massive anti-smoking campaign that was very successful from the American Lung Association and the government and others. And you can see that reflected back in this button from 1986 that said, "Kiss your butt goodbye." Now, what happened is that was remarkably successful, and we've decreased the incidence of lung cancer over that time. However, what we see is there's still a large population of people that are getting lung cancer that have never smoked. And we were kind of blind to that before when everyone was smoking. And you can see that reflected now in the changing messaging from public awareness campaigns, culminating in 2019 with the Go-To Foundation for Lung Cancer, reminding everyone that anyone with lungs can get lung cancer. And in fact, what is worrisome is that we're seeing an increasing proportion of lung cancer in never smokers. And for the rest of my talk, I'll be talking a lot about never smokers. You should know that in the research community, a never smoker is defined as a person who has smoked fewer than 100 cigarettes in their lifetime. Anyone that smoked more than that would be either a current or a former smoker, depending on their current smoking habits. So in this nice study in 2019, Pelisoff et al. Performed an analysis of 3 different large medical institutions and looking at the percentage of lung cancer patients, either non-small cell lung cancer or small cell lung cancer, NSCLC or SCLC, that were in never smokers. And while small cell lung cancer usually occurs in smokers only and has remained relatively steady, what we see is that non-small cell lung cancer, that is the most predominant type in non-smokers, has increased over the past several decades. And there's a really kind of hot debate in the research community now whether this really reflects a growing incidence of the disease, or if this just reflects the changing smoking habits, and this is a larger proportion of cases in non-smokers. But several studies, including this one, concluded that it does appear that there's an increasing incidence of lung cancer in never smokers for unknown reasons. Now, another interesting fact is that even if you subdivided this to its own disease, lung cancer in never smokers, shown here with the NS, would actually constitute the 7th leading cause of cancer deaths. So it's clear that even if we were completely preventing lung cancer due to smoking, we would still have a significant proportion of cancer mortality occurring due to lung cancer. Another worrisome pattern is that we see that women happen to be disproportionately affected by lung cancer cases in never smokers. So the percentage of lung cancers in never smokers that are in men versus women is much higher for women. So in the United States, about 3/4 of lung cancers that occur in never smokers are in women, and the remaining quarter in men. And we see that pattern repeated regardless of the geographic location, with the majority of never smokers with lung cancer being women. And right now, there are a lot of theories about why this might be, but in fact, we really don't know why women tend to get this form of the disease more than men. Some initial clues came in this study by the Cancer Genome Atlas in 2014. We and others performed mutational analysis in 230 non-small cell lung cancers that included mostly smokers, but also some light or non-smokers. And please ignore the colors for now, that's not important. But what these are different genes that are frequently mutated in lung cancer. And when you see this little symbol, that indicates that this gene was more frequently mutated in smokers, or if it's on this side, it was more frequently mutated in light and non-smokers. Likewise, we saw that there were gender differences where men had certain genes that were more frequently mutated than they were in women, and vice versa. And so it's clear that these demographic factors of smoking status and gender actually influence the biology of lung cancers. And so that led us to think about a few questions. The first was, are there new mutations in lung cancers from never smokers that could be targeted with cancer therapies? And that's one particular angle that I won't have time to talk about today, but we're very excited about. Most of the previous genome-wide studies have focused on smokers, and so we just don't really have enough data on never smokers to have identified some of these potential drug targets. But what I want to talk about today is whether the mutational profile of the cancers themselves can tell us something about the intrinsic or extrinsic genetic risk factors that I mentioned. And so for the rest of my talk, I hope to define to you what a mutational signature is and show you how smoking actually alters mutational signatures, leading to these molecular differences between lung cancers in smokers and non-smokers. So the challenge to answering these questions has been that the majority of lung cancer sequenced to date are from smokers. And so we simply didn't have the type of genome-wide data that we would need to be able to answer these questions. That's why I was really excited when I joined the Hutch a few years back and I was introduced to Dr. Garnet Anderson. She is a PI of the Women's Health Initiative, which was a large observational study and clinical trial that began in the 1990s to profile the risk factors leading to breast cancer. And what she and others did was really remarkable because they followed a group of over 100,000 women starting in the mid-90s, and they tracked their health status over time every year through surveys and follow-ups, and they collected multiple different samples from them, from their normal tissue, and if they developed cancer, they went back and also collected tumor tissue from these women. So talking with Dr. Anderson, we realized there was a really important opportunity to identify a cohort of women who developed lung cancer who had never smoked. And in particular, this is a little bit unique compared to some other recent studies that focused on young individuals. And here we're focusing exclusively on postmenopausal women who have never smoked. As I mentioned, they collected this extensive metadata and that included not only their own smoking status, but also the history of secondhand smoke exposure, occupational exposures, and other demographic data. And Dr. Sita Priyamurthy is a postdoctoral fellow in my lab, a really talented, wonderful scientist who has been leading the computational analysis of this sequencing data. So the study design was that we took peripheral blood, fresh frozen, as a normal tissue control. And we were able to obtain lung tumor tissue, which is formalin-fixed paraffin-embedded tissue from each of these individuals. We were able to collect these samples from 57 never or light smokers and 18 heavy smokers that we included as a type of control and comparison group. And then we performed custom whole exome sequencing data, which sequences all the protein coding regions of the genome. We were then able to identify single nucleotide variants, or SNVs, and insertion deletion mutations, or indels, as well as copy number variants, or CNVs. And using this data then, we can identify previously identified important mutations in lung cancer, as well as novel mutations, which have important implications for personalized therapeutics. We can also perform the mutational signature analysis that I will show you today, and then link this to the WHI curated metadata to provide insights into the molecular mechanisms of lung cancer development in these individuals and identify potential risk factors that we hope will lead to improved screening and risk mitigation in the future. So before I show you some of the genetic data, I do want to distinguish between germline and somatic mutations. And all of the analysis I'll show you today is based on somatic mutation detection. When we talk about germline mutations, these are mutations that are either inherited or are de novo mutations that occur in the egg or the sperm, so that the mutation is present in the gamete at the time of conception. That means that the variant would be present throughout the entire person's body, in the development, as well as the adult tissue, and in every cell of the body. In contrast, somatic mutations are mutations that occur at any time after, during or after development, so after conception. These would be restricted to a particular cell or part of the body. And in the case of cancer, we think of them as kind of a tumor-specific mutation, right? So that mutation was present in the cell that founded the tumor, and that mutation is going to be unique from something found in a normal tissue. So both of these types of variants can be important for cancer biology. BRCA1 hereditary mutations are an example of an important germline mutation that confers a risk. But somatic mutations are the ones that might be induced by environmental factors due to exposures. And so those are the ones that we'll focus on today. So what Sita did is she was able to compare the tumor and normal tissue to identify somatic mutations. And then the first thing she did was just assess the overall mutational rate in smokers and non-smokers. And so here she's color-coded the samples from heavy smokers in red and never and light smokers in blue. And you can see that on average, the heavy smokers have a higher mutational burden across the protein coding regions of the genome compared to the never and light smokers, which are in blue. Now, we do see a few outliers of never smokers that have high mutational burdens and heavy smokers that have low mutational burdens. And she's actively trying to dig into that metadata now to see if there are any other factors that could explain these outliers. Now we wanted to look and ask, what are those mutations? And for that, we started to do this mutational signature analysis. And the way I like to think about mutational signatures comes back to this analogy I always like to talk about, but is getting increasingly dated, which is this idea of finding a typo in the phone book. So hopefully some of you are as old as I am, so you remember that there used to be this big, gigantic book where you had to look up people's phone numbers if you wanted to call them. And looking for mutations in the genome is a little bit like looking for a typo in that big book. Before computers, it would have been very difficult, but now with computational power, it's trivial to compare two copies of the phone book and say, what's the difference? And if you do that, comparing the tumor to the normal tissue, you can find in some cases these differences, which are somatic mutations. So let's say we found one here. What that actually looks like in terms of the human genome is you would have a letter or a base that was changed from the normal sequence. So in reality, the human genome is huge, so it's really more like finding a typo in 200 copies of the phone book, but same idea. So then what exactly is a mutational signature? Well, the way I like to think about it is if one of these mutations is in a single gene, let's say a single line of the phone book, then when you think about this mutational rate and all of the mutations throughout the genome, you see there are many scattered throughout the genome, and you might think that they seem pretty random and pretty unrelated. But what if I told you that each of these typos was actually the same change from a C to an A? Would that tell you something about the possible mechanism of how these typos were created? In this case, I would think maybe the printer had a problem that had systematically changed all the C's to the A, and that would tell me something about why these typos were there. So it's the same idea in the human genome for mutational signatures. When we see these patterns of the same type of mutation, it can give us clues about the cause of these mutations. And in fact, C to A mutations are uniquely caused by the carcinogens in cigarette smoke. So if we saw a different pattern, we might think it was due to aging or radon exposure, or in some cases something else. Maybe we don't know what the underlying cause is, but we can see that the mutations come from the same mutational process. So with that idea in mind, Sita performed mutational signature analysis. There have been a compendium of over 30 different types of signatures defined by the Sanger Institute in the UK. And so we use those as reference signatures. They just have numbers here and as an example. And what we see is that smokers and non-smokers have strikingly different mutational signatures. So smokers have an abundance of this signature 4, which is the C to A type mutational signature caused by cigarette smoke. And this has been nicely demonstrated in cells in a dish before, that the cigarette smoke actually can directly induce those types of mutations. In contrast, the never smokers, we don't see evidence for signature 4 mutations. These are just 4 examples here. Instead, we see that almost all of the mutations in the tumor have a pattern of this signature 1, which is associated with aging. So scientists consider this a kind of molecular clock signature, that basically the older you get, the more cell replications your cells have gone through, cells tend to accumulate these type of signature 1 mutations. So we're seeing very different patterns between never smokers and smokers. Sita is now looking, in some cases, we see unknown signatures. And so she's trying to understand if those are really validated and what potential mechanisms might explain that. We know you can get mutational signatures due to intrinsic genetic issues as well. So there are DNA repair defects and other kind of endogenous processes that can give rise to specific signatures. And so she's currently trying to identify if any of those might be at play in never smokers. So in conclusion, I hope that you leave the talk remembering that anyone with lungs can get lung cancer, and increasingly this is very important because we see this rising incidence of lung cancer in never smokers, and yet diagnosis in these individuals continues to be very difficult and often delayed because it's not well known that a young person my age might come in with a cough and actually have lung cancer. The differing mutational signatures in smokers and never smokers point to a different underlying etiology in these two groups. And a future direction that I didn't have time to talk about too much was that the etiology of lung cancer in younger versus older patients may also differ. And what we're seeing in that respect is that we don't see chromosomal translocations that are kind of a hallmark of lung cancer in younger people. We're not seeing those in postmenopausal women. And so we think there may be these kind of different etiology by age of presentation as well. So with that, I would just like to acknowledge my awesome lab. This is clearly pre-pandemic here, and Sita has done the majority of the work that I talked about today in collaboration with Dr. Garnet Anderson, Amy Pigurigan, and Gavin Ha. I'd also like to thank the patients and their families that participated in the Women's Health Initiative, as well as our funding support from many different foundations, but including most importantly, the Prevent Cancer Foundation, which has allowed us to move into this new direction of cancer prevention that I'm really excited about. So thanks for your attention. I look forward to the panel discussion.
Hello, everyone. I'm Sancy Leachman, and you can also see Lisa Aspinwall. We are going to be presenting a really great topic for us, sharing genetic test results with people at high risk of melanoma to motivate behavior change. And we'll be talking about, in particular, a trial that we've done called Behavior Risk Information Genealogy and Health Trial, BRIGHT. And so you'll hear both of us talking about that. We're going to try to accomplish two things with this. The first is to tell you about the data and tell you everything that happened, but also to tell you our story, because this has been a sort of a detective hunt all the way along, and it's something that neither one of us could have ever accomplished alone. So at the start of the project, that was all the way back in 2005. So we've been working on this for quite a while. There was a real controversy in the field of melanoma about whether or not genetic testing for melanoma was helpful, and even whether it was ethical to do it, to provide those results, if there wasn't anything that you could do that was actionable about that. And so go ahead to the next slide. Yeah, and so some of those questions were, don't people already know they're at risk? And shouldn't they already be doing everything they can to prevent cancer or find it in their course? But the thing was, and is it ethical to offer testing when it doesn't change the management in any way? When we can't change their genes. So what are we going to do differently except recommend sun safety and self-exams? But what I was finding in clinic, I found a different story sort of starting to unfold with my patients. And I found out that knowledge really empowered the patients to behave in different ways. And I found that, that patients that seemed to receive these results, they were complying better with my recommendations. And so I started to ask that question, shouldn't we be trying to include the genetic test reporting as part of the clinical care for these patients, because it was enabling them, empowering them in some way. But I had no experience in behavioral work. I was a molecular biologist and a dermatologist. I had no experience, and I needed a partner. And that is where Lisa came in. So Lisa, I'm going to turn it over to you to talk about your experience.
Thanks, Nancy. So I am a social psychologist with a specialty in health psychology, and I study how people think about health risks. And at the time I arrived at the University of Utah and had the good fortune to meet up with Sancy, I was studying health risks, but having to make them up so that I could create experiments where I could vary their severity, their age of onset, their preventability, and other key things to try to understand how people think about health risks. And I was studying these things in people who were not at any special risk, like the people we're going to be telling you about today, but people who are at population risk, not high risk. So most of the challenge for social psychologists and health psychologists is how to get people who don't think they're at risk to appreciate that they are at risk and they need to be taking preventive measures. What we're going to see is that when you look at hereditary cancer risk assessment and genetic counseling, you have a very different situation where you have people who are at very highly elevated risk, but at the same time are perfectly well. They have no symptoms. And so when we're asking people to undertake behaviors for cancer prevention and screening, that's a big ask. If you feel fine, we don't like to do things that are expensive or inconvenient or embarrassing or boring or time consuming. So how do you get people to think about those things? So today we're going to share with you what we've learned in 16 years of asking questions about whether and why adding genetic testing to the more traditional forms of patient education motivates improvements in prevention behavior. We'll turn this back to Sancy.
Yeah, so now it's my turn, because as the clinician of the pair of us, I want to bring everybody up to speed and on the same page with some of the basic information you need to understand about melanoma and our patient population, so that you can see why we designed the study that we did and how it went. So first of all, melanoma, it's really important that you understand melanoma is there's a genetic component and there's an environmental component. And what melanoma is a cancer of those melanocytes. And those melanocytes are present in that basal cell layer. And UV light reaches down through the epidermis and hits those skin cells. And basically, the melanocytes are the cells that make brown pigment. So when you get a tan, the reason you get a tan is because the UV light has come down, caused DNA damage, which signals the cells in the skin to encourage the production of pigment. It's an SOS sign for the melanocyte to save itself and the keratinocytes around it. And so the important thing about that is that everybody as an individual has a lot of different combinations of genes that make this environmental exposure more or less risky for them, right? And so you can see that UV light is one of the things that we want to avoid if you're a high risk patient. So go ahead to the next slide. The other thing that I think everybody in the group hearing this should know is that melanoma is a deadly cancer. Sometimes you hear the comment, well, it's just skin cancer, just cut it out and you'll be fine. But melanoma is in a different class. It really is a deadly cancer, and it's most deadly if it's caught late. So the thing about melanoma is that if you catch it before it's had a chance to spread to other parts of the body, your chance of being alive in 5 years is 98%, but it's a totally different story. If you catch it after it's spread, it's about a 24% chance that you'll be alive in 5 years. So catching it early makes a big difference, and prevention of it happening in the first place has the potential to be, revolutionary for the field. So what are the things that you can do? There's a few things that we recommend all the time in clinic, and that's sunscreen, protective clothing, avoidance of UV light, self-skin exams, and provider skin exams. And this shows, this slide is basically hammering that message home, right? The first picture is a picture of a family that shares a lot of risk factors: red hair, lightly colored skin, blue eyes, freckles, and they share those traits, but those traits are really common throughout the population, and they don't individually or even together, they don't increase your risk by a huge amount, just an amount that would be around a 4-fold higher risk or so. But if you look at the other picture, that's a picture of a pedigree. And in that pedigree, I think you can see that people in that family, those are all family members within a single family that we worked with in Utah. And you can see in the green highlights, those are people who have pancreatic cancer. The red ones are all of the melanomas in the family. And there's one that's a black square that's a melanoma in pancreatic cancer. And what that demonstrates is that this is a heritable thing that is high risk. If you get a mutation in that gene, in this case it was a P16 or CDKN2A gene, if you get a mutation in that gene and you pass that gene on to the next generation, which is a 50% chance, you've only got 2 copies, you pass on the good one or you pass on the bad one. If you pass it on, then they have a very high risk of getting a melanoma. So go to the next slide. So I'm going to ask you guys some questions. What is the percent chance that a person with red hair will get a melanoma in their lifetime? Now you guys think about it, okay? I'm going to ask you one more question. What is the percent chance that a person with a P16 mutation will get a melanoma in their lifetime? 4% on this one. What do you think the next one is? Okay, 76% lifetime risk. So here's another question then. That raises, that comes back to that original question. If they know that risk, aren't they already doing everything they possibly can? So how likely do you think these patients are to follow our recommendations for using sunscreen? And I'm not going to answer this question. Lisa's going to go on here in just a minute to talk about how we get to the answer of this question.
So I want to share with you the results of 2 studies. Here is our first one, and it's going to give the answer to the question that Sansi posed in just a moment. So in our first one, we had the opportunity to provide clinical genetic test results to a sample of 60 people who had participated in prior research, including the gene discovery research that allowed the P16 gene to be identified. What's important here is that 1/3 of these family members had a diagnosis of 1 or more melanomas, often as many as 9. Some people had 3 melanomas, but 2/3 were unaffected, meaning they have no prior diagnosis and no personal history. So why are we focusing on the unaffected people? Well, the idea with precision medicine is that you'll be able to tip people off ahead of time before they develop a disease to know that there are certain things they should be doing in terms of prevention and screening that will improve their health outcomes. Now, what about the proportion of people who practice protection in the sun or photoprotection? In the gray bars are family members from this initial study who've had a diagnosis of melanoma, and in the red bars are members of the same families who test positive for that P16 gene we've been telling you about, but who do not yet have a personal diagnosis of melanoma. And the first thing you'll notice is that the red bars are a lot smaller than the gray bars. And so when we asked you what percent of people use sunscreen, if you're looking at people from these families who have a history of melanoma, that'll be around 55%, but it's only 30% for members of the very same families who have tested, who will be told that they've tested positive. So this is at baseline before they've received any information. And you can see that people are more likely to say they wear protective clothing, long sleeve, broad brim hat, or that they avoid peak exposure and try to stay in the shade. Nobody likes sunscreen, it's sticky and expensive. But the important thing here is that these adherence rates are probably lower than the numbers you were expecting to hear. So does genetic testing provide benefits? So our first study, we provided those clinical genetic test results, and then we followed people another 5 times over the next 2 years. And what we found is those unaffected carriers, test positive but no personal history, report improvements in how thorough their skin self-exams were in terms of the number of body sites they examined, greater adherence to annual total body skin exams with a medical professional, greater reports that sun protection was part of their daily routine, greater use of protective clothing, reduced number of sunburns, and these gains were sustained at a 2-year follow-up. Importantly, the provision of that positive genetic test result did not create increases in anxiety, depression, or worry about cancer, and patients reported multiple benefits, both informational and behavioral. They reported a greater understanding of their risk and greater motivation to practice photoprotection and screening. So far so good. And we were very, very happy and encouraged with these findings. But does genetic testing really provide benefits? So one tricky issue in the study of genetic counseling and test reporting is that you can't provide the genetic test results without the accompanying education. And that asks the question, well, maybe it's the education and counseling about family history and about medical management, prevention, and screening. Maybe you don't need an expensive genetic test, right? Wouldn't it be important to show that there's something about the test that is motivating and informative in a way that the accompanying education of patients without a test isn't? So we set out to design a study to test whether there's an impact of genetic test reporting over and above the receipt of standard recommendations based on family history. So this brings us to the BRIGHT project, that behavior, risk information, genealogy, and health trial that was funded by the National Cancer Institute. All of the study participants are unaffected members of high-risk families, and by high-risk families, we mean families that have at least 3 first or second-degree relatives with confirmed diagnoses of melanoma. Many of these families had many more affected family members. All of our participants are unaffected, so no one in the study that we're about to share with you has a personal diagnosis of melanoma. We're going to come up with a prospective, non-experimental control group. This is a mouthful. This is a simple way of saying it's unethical to randomly assign people to either get or not get genetic test results, or to get positive or negative results. You have to give people their actual test results. But we came up with a meaningful comparison group of members of high-risk families who have the same rates of melanoma and merit the same management recommendations, but they don't carry the P16 gene, and no one knows what it is that they do carry. So we're not withholding a test from these folks. They're not eligible for P16 testing because their families don't carry a P16 mutation. And I'll say more about this in a moment. So we're not randomly assigning people to results. We're taking advantage of a natural experiment that involves 2 different kinds of families. We're going to provide individualized cancer risk assessment for each patient with or without genetic testing. So the no test controls that we'll be talking about receive counseling based on family history alone, but no test result. We're going to compare them to people who get that test result. Okay, so here's a schematic to try to help us share with you the logic behind having these 3 groups of participants. So we're going to start with P16 families. They are the people for whom genetic testing is available. So you take the test after education and informed consent. If you are positive, you're going to show up in the slides that we're about to share with you in red. Your risk that you are counseled to have is 70 times population risk, or up to 76% for US residents. If you test negative, you will be in black. Your counseled risk is twice population risk. So notice that the presence of the test affords, for members of the same family, there's a huge difference now in what we can tell people about their risk. It's either 70 times or it's twice population risk. Now, if people are in what we'll call a non-P16 family, these are the families that have been found through prior testing of their more senior relatives not to carry this mutation. Genetic testing for P16 makes no sense for them. They're not eligible. There are no test controls. They're going to show up in blue. What risk estimates do they get? 30 to 70 times population risk. So you're told this almost the same risk information as our P16 positive carriers, but we can't be more precise because there's no gene to test for. Okay. And as I mentioned, we have assessments at baseline, post-counseling, 1 month, and 1 year. Okay, I'm going to do something unusual in talk. I'm going to show you the one slide where there's no differences across the group. So what I'm talking about is questions that we asked people from baseline, post-counseling, 1 month, and 1 year. How much do you understand about melanoma itself? Something called illness coherence. And what you can see is kind of a phenomenon where education lifts all boats. All 3 groups of patients report a better understanding of melanoma following the individualized counseling they received. Here's where things start to get different. If instead of asking how much do you understand about melanoma, you ask how much do you understand about your risk? What does it mean? How did you come to have this risk? Here's where we're going to see the P16 groups, those in the red line and the black line, taking off and being very different from the blue line, even though people got exactly the same education and counseling. The only thing that's different between these sets of families is whether you are eligible to get a test result. So what you can see here is that people who got a genetic test result reported a greater understanding of what their risk meant and how they came to have it. If we look at comparative lifetime risk compared to other people, your age, gender, and skin color, what's the likelihood you'll develop melanoma in your lifetime? You can start to see a huge difference between the red line and the blue line. So in the red line are our carriers with their positive test results. They come into the study thinking they're somewhat above average in risk. They get that positive test result. This goes to the right answer, which is much above average because they are 70 times population risk. But look at the blue line. Their risk perceptions are unchanged. And we see this on other ways of asking people about perceived risk. They're saying somewhat above average. The right answer for them really should be much above average because they're 30 to 70 times population risk. And then in the black line, we see that the non-carriers report that their risk is still above average, but it goes down from what they thought at baseline. And that is accurate and appropriate on their part. What about other ways of thinking about risk, like the urgency and priority? Is dealing with your risk of getting melanoma a priority? So everyone in these families knows that they have this risk, but how much is it something that people feel they need to take action on? Here is where we also see a significant increase in people who test positive, shown in the red line. So compared to their baseline, they already believe it's a priority, but this moves them up closer toward that strongly agree. And those differences are maintained 1 year later. The reason that I want to emphasize this slide is notice the blue line, we don't see any change in prioritization of risk. These are all patients who have had a half-hour-long individualized cancer risk assessment with a genetic counselor, received a research-based, extremely thorough total body skin exam and detailed education about what to do. Their priority is good, it's at 4 out of 5, but it does not increase as a result of receiving this risk education. It does increase if you got the risk education plus that genetic test result. Notice that it doesn't go down among those non-carriers in the black line. Another reason I want to emphasize this is that this priority of risk measure is a very successful predictor of who is going to increase their sun protection behavior up to 1 year later. So prioritization of risk is a massive predictor of improving your behavior following genetic counseling and test reporting. We see a similar pattern when we look at motivation to reduce sun exposure, perhaps the most important measure that we have. That is higher both 1 month and 1 year later among those carriers who got that positive test result than among the no test controls who were told they were 30 to 70 times population risk. Okay. Now I'd like to share with you two of our kind of cooler measures. This project was a lot of fun to be involved in and work with photobiologists and engineers. Everyone was equipped with a dosimeter that looked like what was a watch band with maybe half of a marshmallow on it. If you cut a marshmallow in half and stuck it on there, it was a white disc. It didn't show patients any information, and it was recording their UVR dose in 10-second intervals every day for 27 days, for 3 sets of 27 days. So patients were very generous about wearing these things for as often as they did. And so this is going to compute what's called a standard erythemal dose, which corresponds to how much it takes to produce a slight reddening of the skin as you would get in a mild sunburn or being on your way to a mild sunburn. Okay. The reason that we're interested in this is that it's an objective measure. It's very hard to remember how much sun you've gotten, let's say, over a year. I don't know how many of us, well, maybe with the pandemic, if you were working inside, it would be an easy answer, no sun. But for most of us, that would be a really difficult question to answer. But with these dosimeters, we can actually see how much UVA and UVB people have been getting in those 27-day windows. And what you can see in the red line here is that carriers show a unique decline in their average daily UVR dose that's being received by the dosimeter on their wrist 1 month after counseling, and that both carriers and controls at 1 year show a significant decrease in average daily UVR exposure. So both groups are doing a better job of staying out of the sun. There's no change in the non-carriers, but it's the carriers who show a more rapid drop up 1 month after counseling, and importantly, that is sustained 1 year later. Very important for behavior change to look and see how long it lasts. Okay. Our next cool thing that we did was to use a laser-based measurement to assess skin color at typically exposed sites. So the sites that we'll be talking about are the dorsal wrist, the outside surface of your wrist, and sites right at the face. The reason we're interested in this is that the dosimeter measures how much sun the dosimeter got. But if people are wearing long sleeves or wearing sunscreen, they are protecting themselves against the sun. So where the rubber hits the road is how tan were people? How much change was there in the color of their skin at typically exposed sites like the wrist and face compared to those that are not typically exposed, like the inside of your upper arm or just below your waistband. But here's what we find. If you look first at the wrist, you can see that the red line uniquely shows a decrease in how objectively tan those carriers are after receiving a positive melanoma genetic test result 1 year later. We do not see this in the other two groups. In terms of melanin index scores at the face, there were no differences and no decreases in the groups. If you look at the two graphs, you can see that a higher number means more tan. People were less tan on their faces. We suspect that's because people take better care of the skin on their face, often through the use of cosmetics that contain at least some sunscreen. Okay, so where does this bring us in terms of understanding the impact of genetic testing on how people might manage their familial cancer risk? So what we're looking at is how genetic testing has the potential to increase people's understanding of their cancer risk and their prioritization of its management. And what we were not able to show you in slides today is the provision of that genetic test also increases people's sense that those management recommendations that their doctors are offering to them apply more to them. And as we've seen, they also increase people's motivation to perform them. What this does is it brings us one step closer to the goal of understanding how genetic testing can promote both personalized medicine and, as Sansi will explain, personalized prevention. Please take it away, Sansi.
Thanks, Lisa. So I think everybody in this group, I don't have to sell you on prevention. You know that an ounce of prevention is infinitely better than treatment for something, for a cancer. That's the way we all feel. And what we've shown, what I'm excited about, is two different things. The first is that if we want prevention to take hold in our society as a major way of preventing, of really dealing with cancer, we have to tackle the behavior problem. And this is broader than just behavior for melanoma. What this is telling us is about how you get to people, how you help them to help themselves. And that's really what this is about. And so it's much broader than, it's in the whole field of medicine, how you do this, not just this. The second thing that I'm excited about is that this is about, if you think about the progress of medicine over the last decade, where we've been moving is toward precision medicine, where we actually apply a precise medicine or a precise tool to the disease that we're treating. And now what this is talking about is being able to apply precision prevention.
Okay, wow, that was just a fabulous and interesting discussion there about the cross-section between behavior modification and genetics. I think all of our speakers have provided us with some great content and insights and information. So we're going to move on to our Q&A. Anybody who would like to ask a question or make a comment can do so by clicking the Q&A icon on the bottom right-hand side of your screen. So we do have a few questions coming in. first and foremost, Dr. Berger, I think we have a question around never smokers. Could you once again define what a never smoker is? And could a person who perhaps has been exposed to secondhand smoke or even pollution be considered a never smoker?
Yeah, so for the purposes of my research, a never smoker is simply someone who hasn't themselves smoked more than 100 cigarettes, because beneath 100 in your lifetime, we think that your risk is basically indistinguishable from someone who has never smoked. So secondhand smoke is not really incorporated in that. And really, there haven't been a lot of good data sets to directly look at the relationship between secondhand smoke and smoking-induced mutational signatures, which is one of the things that we are addressing. And interestingly, we don't see really any of that smoking signature number 4 in the never smokers. So even if they lived with a smoker, we're not seeing substantial accumulation of the smoking-related signature. So, my initial thought, and our study is not complete yet, but it doesn't seem to be that secondhand smoke is majorly contributing to lung cancer in never smokers. And I think that's been borne out in the epidemiological data as well. Pollution is another thing that has been linked to a minorly increased lung cancer risk, but we don't have any good sense yet if there's specific pollution-related signatures, and that's something that we'd like to look at.
Great, thank you so much. Dr. Leachman, you mentioned the concept of precision prevention, which is a great idea. To all of our speakers, how can we as patients and providers potentially on this webinar or across the US foster better or improved acceptance or uptake of genetic testing? And then also the increased screening or behavior changes that are needed to reduce cancer risk or catch it earlier. So I guess we'll start with Dr. Leachman since you brought up the concept, but I'd love to hear what the other speakers have to say as well.
Right. Well, I'm not sure how you motivate people. That's the exact point of our project. We hope. Can you guys hear me? I just want to make sure. Can you hear me?
Yes.
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 Okay. So precision. What we want is we want people to understand that their genetic background can reveal their particular vulnerabilities. And so no one can put into practice every single prevention behavior that's available to everyone all the time. But if you can hedge your bets a little bit, right? If you can identify the risks that you have through your genetics, and then go forward and institute the prevention behaviors that are most appropriate for your particular risk. That's I think a motivating factor to get people to see that, oh yeah, this is probably worth my time to put.
Whoop, I think we might have lost Dr. Leachman. She's frozen. So Heather, this is sort of up your alley. You do a lot with hereditary cancer risk, and modifying behavior or increased screening is a big part of that. So do you have a take on this, on ways that we can impact understanding and uptake of genetic testing and these additional screenings or changes in behavior?
Yeah, I think it's critically important, Lisa, because, we probably all just heard this last month the exciting news that the USPSTF has dropped the screening age in the general public for colorectal cancer to 45, which is great news because there's been a tremendous increase in early onset colon cancer. But that's 20 years too late for someone with Lynch syndrome. And this always makes me a little bit crazy because you first, I feel like the first step to figuring out your proper cancer prevention and screening is to determine whether or not you have a hereditary cancer susceptibility. And I think a lot of people are missing that step. And I don't know what's going to take. I think we are increasingly pushing testing out to larger populations. It used to be just the families with the most significant histories that would get referred into CS. You're seeing a shift now to where every cancer patient is starting to be offered genetic testing at the time of diagnosis. But those of us who are trying to prevent cancer would like to prevent that cancer in the first place. And so I think there is also increasing interest about doing some sort of population testing in young adults in time for you to know if you need to start your screening at 20 instead of 40 or 45. But getting a test pushed out to the whole population is a logistical challenge. I mentioned newborn screening in my talk. That's one opportunity, but where you have everybody, but most people don't think the newborn period is the best time to be talking about adult onset cancer susceptibilities. And once you hit 18 to 20-year-olds, it's pretty hard to capture them. So this is something we have to talk about. And you're right, there's 2 points here. One is getting people tested so they know if they have a hereditary cancer susceptibility or not. And the second step is getting them to be adherent to the management recommendations that we make when they do test positive, or even general population recommendations, which we know many people in the population are not adherent to. So I really enjoyed Lisa and Nancy's talk today with that regard.
Yeah, it's fascinating. I've actually heard that speakers say that hereditary cancers are in fact mostly preventable cancers. And so it's really a question of, the uptake of the increased screening or risk reducing interventions. And we need to figure out how to do a better job of making those easily accessible and accepted. We do have a question here, and I don't know who might be the appropriate person to answer it, but how does being a child of an Agent Orange veteran potentially change cancer risk? So obviously we know Agent Orange has an impact on individuals who were directly exposed, but does it potentially affect offspring of those individuals? That's a tough one.
I know. I'm not sure we have an expert on this topic on the panel today. With me and germline genetics, that would not be affected by the Agent Orange exposure. But I think we are starting to look into this. As you said, Lisa, I think we're much more clear about what the cancer risks are for people who were exposed themselves. And now just getting to that next generation and starting to see what the impacts might be there.
Right. So I guess that's an area that probably needs further study. So we've been talking a lot about genetic testing. And so we do have a question around, is genetic testing covered by insurance? And I'll start just from my own expertise, and that is genetic testing is covered by most insurers if you meet specific criteria for testing, whether that be personal or family history of cancer. It varies by insurer somewhat, whether you have Medicaid or Medicare or private insurance. And I think it also varies if you're talking about tumor testing versus germline testing. So Heather, can you share some of your experience? And then I'd like to hear more from maybe the lung cancer or melanoma side about insurance coverage of these tests.
Yeah, this has been one of the best improvements in cancer genetics since I've started doing this 25 years ago. And I think we all remember at its heyday, just getting the BRCA 1 and 2 test done was over $4,000. And now because of multi-gene testing panels, competition between the laboratories, there are patient pay price as low as $250. And that would be if your insurance company did not cover it at all and you were paying out of pocket. And that's for multiple genes, not just 2. It could be panels as big as 50, 100 genes. So I find it's very accessible now when it didn't used to be. I also like to point out that patients on Medicaid, by definition, meet the criteria for financial hardship at these laboratories and do not have to pay for testing. And we also get coverage for most Medicare patients. So you're right. Between there, the third-party insurances, it comes down to whether you meet criteria or not. But if you do not, you always have the patient pay option available, which is much more affordable than it used to be.
Absolutely. So we know through our work at Force that Germline testing, so hereditary cancer testing, is available for as little as $50 to $250. So
Yep.
it's not out of the realm of out of reach for many people. Let's move back to, I guess, our friends in the melanoma space. What's your experience with insurance coverage of genetic testing? Dr. Aspinwall, do you want to, or I don't know, or Dr. Leachman?
Well, it would be Dr. Leachman for insurance.
Okay.
And I'd like to go back to the previous question when we have a chance.
Fabulous, thank you. Go ahead, Dr. Leachman.
Okay, well, we have fairly good luck with getting insurance covered as long as we can demonstrate that it's a high probability, a high pretest probability of being able to find gene. So we know that in melanoma, if you have that rule of threes, or three melanomas in the family, and there's criteria. If you're following the criteria, we've got publications that show that there's a pretest probability that makes it worth testing. And so when we can show that to the insurance companies, we have pretty good luck.
That's great. And we will circle back to Dr. Aspinwall in a moment. I do want to make the point you were saying about, the convincing information or evidence. Seeing a specialist is very helpful. So either a genetic counselor or an oncologist, or somebody who has expertise in a particular type of genetic cancer, because they understand what is needed to validate coverage for the insurance company. Many primary care providers just don't have that knowledge, and that's where we sometimes see we run into trouble as far as coverage goes. So, Dr. Aspinwall, you wanted to circle back to that last question. I think, was it regarding Agent Orange?
No, it was regarding precision prevention. And so most of our discussion today across the panelists has been with identifying people who are at high risk for hereditary cancer. One of the things that we're doing with the BRIGHT data and with other studies is looking not only at people's genetic susceptibility, but are there particular beliefs that make people more or less likely to take action after receiving genetic counseling. And so some of these have to do with whether people believe that their behavior can affect their genetic risk. And we find something very interesting. People who believe that their risk is high, but it could be even worse if they practiced unhealthful behaviors. So for example, smoking or sun exposure. That set of beliefs does a wonderful job of predicting even more behavior change over and above the effect of the genetic test result itself. Similarly, members of these high-risk families say, I believe that healthy behavior can reduce my genetic risk. That also predicts better behaviors. And we see very low endorsement of the one thing that everyone was worried about when we first started this work, which was deterministic beliefs about risk. So if I have this high genetic risk, it's in my family, there's nothing I can do about it. Our patients do not agree with that, by and large, and it's generally unrelated to changes in behavior. So I think that part of the puzzle for thinking about prevention is trying to understand how people think about genetics as much as it is understanding how the genes actually work or how environmental exposure actually confers risk for certain people. So I just want to put in a pitch for thinking about how people think about these risks.
Absolutely. Wow, that is interesting. And your work is really meaningful because we know that some people are averse to even testing for their own reasons. But then if they do get tested, if they don't, do the necessary things to either catch cancer early or to prevent it, then the testing is really for naught. So, well, we are now ending our time left so we have to wind up this discussion. We are going to thank all of our speakers who have just been so wonderful and so informative. And we value their expertise and work with the cancer community. We'd like to, we're going to be moving on now to a 2-minute break. And then we have a sponsored session from Exact Sciences about the current challenges in colorectal cancer screening. And that'll be starting at 2:05 Eastern Time. To get to that session, you have to click the X to close this window and then go to the View Sessions tab. at the top of your screen and choose webcast 3. So we thank you for joining us today. Thank you again to our speakers and to Prevent Cancer Foundation for hosting, and we'll look forward to seeing you in the next session. Have a good afternoon.